Hello, I'm Dr. John Cranham, and I'm with the Chesapeake Center for Complete Dentistry. The title of this presentation is Cosmetic Dentistry for You? Dentistry has evolved to a place now that we have so many methods and materials, different types of porcelains, different techniques to bond things to teeth, that we can do dentistry that is almost indiscernible from natural tooth structure. Yet cosmetic dentistry by definition is doing dentistry on a patient that has no disease, but only to alter the patient's appearance. And that may be where you stand, or you may be a patient who's had dentistry or had some disease processes going on, whether it's gum disease or maybe you've had trauma and lost some tooth structure, and now you're trying to restore what's there. Regardless of which type, there are principles that need to be thought about with regards to designing a smile to get a great result. And my goal in this presentation, this short webinar, is to just apprise you to some of the things to look for when you're choosing a cosmetic dentist or a restorative dentist to do your work, and also some of the principles that you should understand that makes a smile beautiful. So what I'm going to do in this webinar is basically show you some of the principles that go into smile design, and then show you 4 or 5 cases, examples of different types of scenarios where we have done some nice work and gotten a great result for our patients. So the first thing that when we're treatment planning and looking at a patient and thinking about smile design, there is the aesthetic component. And so when we're looking at a patient, the first and foremost thing is not just to think about what procedure you're going to do, but to step back, analyze the patient, look at how the teeth fit in the patient's face, look at the proportions, some of the things that we're going to talk about, and make sure that you are visualizing, or the doctor is visualizing, the things he's going to change before they go ahead and start changing it. And that's one of the mistakes that I see, is that often the process just goes too fast. Doctor looks in the patient's mouth, says you need 10 veneers, and then the next thing you know, they're preparing the teeth. What we're going to talk about is getting very specific data, some photographs, some models, visualizing where the teeth would go, and then thinking about the best procedure to get that done, whether it's a restorative procedure, orthodontics, or some combination. The second thing that we're going to talk about is the function, and this is also extremely critical, because again, you can have the most beautiful result, but if it doesn't function properly, if the teeth don't fit together properly or chew properly, we can actually do things that increase the muscle activity in your chewing muscles that can cause damage to the restorations, cause them to break, cause them to come off, these type of things. The other thing we have to think about is the biologic success and the structural integrity of each tooth, and that really gets into some more advanced treatments for the dentist. But the bottom line is that we have these 4 food groups: getting aesthetically correct, functionally correct, biologically correct, and making sure the structure of the individual tooth, the teeth that we're working on, is intact. The other thing we want to do is always be possibility focused as we look at our patient. So when we look at the anatomy of a beautiful smile, there are 12 things that we think about. And the first thing we're going to look at and understand is that those upper teeth, those social 6 or 8 teeth that we see when we smile, are designed to function in a very specific way. And so what I want you to think about, that as we analyze this as dentists, we are thinking about every specific contour of the tooth, from how it fits against the gum, to how it curves back, to where that edge needs to be for the smile. But also that edge is important as we speak and say F and D sounds. So, missing the wrong edge can not only cause problems with aesthetics, but it can also cause problems with your ability to speak properly. So let's look at an example case, patient who had some previous dentistry that she's unhappy with. We end up looking at this patient, going through the protocols that we're going to talk about in terms of getting the impressions and the photos, and we end up with this result on the right side of your screen. Notice we did 1 more tooth in the pre-op, and we also changed basically the length of the teeth to better tuck under the gums up top, and also to better fit her lip. And so what I want to do is take the post-op of this patient and have you understand why this looks good. Because if you have a good picture in your mind of the specific things that make up a beautiful smile, then perhaps you can take a picture of yourself on your phone and look at it and start to understand the things that maybe need to be changed. And so you can communicate at a very high level, either with me when you come to see our office, or if you're somewhere else and seeing another dentist. I want to make sure that you have all the facts before you have any of these procedures done. So the goal then, when we look at a patient, is the two front teeth are generally about 10 to 11 millimeters long from the edge that you see all the way up to the gum line. That's about the size of a normal tooth. And it can be 10 to 12, but that's generally the range. The thing to understand, though, is that this tooth fits properly in the face. Generally speaking, if you have a normal amount of lip movement from the edge, that in a good smile, that edge is just touching the inside of the lip, and you're just seeing a hint of the top of the tooth as the gum intersects with it. So when you see that, that's the general thing that we see with a real pretty smile. So how do we evaluate the length? Well, we in our workup, we'll take a lot of photographs of you. And one of the pictures that we take is the rest position, where we have the patient just wet their lips and the mouth falls open. And we're looking at how much tooth structure is displayed in this rest position. And in the norm, you should see about 3 millimeters if you're around 30 years old. And as we get older and the upper lip starts to come further and further to the earth, we start to see no upper tooth at the rest position. So generally speaking, regardless of your age, we want you to show some tooth structure at rest. And that's one of the things that we do to determine where that edge should be. We also look at how this edge fits against your lower lip when you smile. The rule is the lip line follows the smile line. One of the most unattractive smiles we see is when you have a beautiful curve to the lip and the edges go the other way, and that all we see is a big black space in the front there. So if the edges follow the curve of the lip, there's no space seen, and that's the prettiest type of smile. And the last thing we do to communicate or to figure out where these edges should be is we do test it with the F and V sound. And again, in our practice, what we do is we visualize everything and do it first in wax on a model. And then when we do the case, we transfer this wax up into your mouth in a provisional restoration where we can test the function and the phonetics. And so if you can't say F and B sounds properly, we'll know that in the temporary stage. And that then allows us to make the appropriate changes in the permanent. So we want to make sure we have the right size tooth. We want to make sure it properly follows the curvature of the lip, and we want to make sure you speak properly. If you do that, then we have the best starting point, which is that proper incisal edge position. Now, once we get the bottom of the tooth correct, or the edge, we have to figure out where the gum line is going to be. And what I want you to think about is from the bottom of the tooth to where the gum line starts, that is how long the tooth is. So the gum position is really the second component of crown length. The other thing we like to see about the gum line is we want to see symmetry. And we want to see the two front teeth mirror images of one another. And if we draw a line from the front tooth, the central incisor, over to the canine or the fang tooth, all those three teeth should be pretty much on the same plane. The middle one there could even be a little bit down. But we're seeing symmetry to the gum line, and we're seeing the gum line in the proper position. What you need to know is if you're a patient that we can get the edges right and the gums are all over the place, we can fix that. We can work with a periodontist, or we can do things in our own office with the laser to get that adjusted where everything is symmetrical. But we have to see that in our plan to make sure that it's necessary. The third thing we're looking at is the piece of tissue between the teeth. We call that the papilla. And if you notice, when you look at her case, these papilla, these little points of tissue, contact somewhere with the contacts of the individual teeth. Some people, when they smile, the papilla doesn't completely fill in that space, and you have these little black holes in the smile that are unattractive. And so when we look at these papillas and we basically attach a line to them. Notice that the line that contact the tips of the papilla as we go across basically follow beautifully the curvature of the lower lip. Those are some of the things that we look at. There's also some science behind the width relationships of teeth, and we call this the golden proportion. The golden proportion exists a lot of places in nature, and with teeth it basically looks at this. If you look at the width of the lateral incisor and assign a value of 1 to that, the width of the central incisor should be 1.6 times the width of the lateral, and the mesial part of the canine or the fang tooth there is 0.6 times the width of the lateral incisor. Now, this is important for people that are missing teeth or have spaces, because here again there's science behind what we should be adding to, and I'll show you some cases later where there's some spacing that we have to figure this out. So we always go back to what exists in nature in a beautiful smile to try to determine what is going to be best for your individual situation. The other thing we know is that teeth are longer than they are wide, and that width to length ratio is somewhere around 80%. We say 75 to 85%. In this example, you have a 10 millimeter tooth that's 8 millimeters wide. It's a great place sometimes to even start, because people that have worn their teeth and ground them down, the teeth are going to get shorter and shorter and shorter. And so when the teeth get square, we have to figure out where we're going to get additional length. And that's part of our both aesthetic and functional design before we actually do the case. Very, very important that we have almost like a set of architectural plans before we go in there and start cutting teeth down. The other thing we want to make sure is, from a bigger picture, that the two front teeth is very close to your midline, but where the two front teeth connect or touch each other, that it's very much parallel with that line running down the center of your face, and then the edges of the two front teeth are perpendicular to that. What we don't want, and what's very distracting, is cases that are canted. So we work very, very hard to get rid of all the cants that exist in your pre-op situation. We also notice that the roots of the front teeth actually are slightly offset to the outside. Teeth don't go straight up and down like a picket fence. They actually curve out so that those fang teeth kind of aim towards your belly button. This is what we see, and again, in a beautiful smile. But from a functional perspective, the reason the teeth are like that is those canines are an important part of the bite. And there's a reason, what we call an occlusal reason, or a functional reason for them to be like that. One of the things to look at for those of you that are missing teeth in the back, particularly lower molars, sometimes the upper teeth can extrude down. And if they're extruding down, you can end up having the back teeth longer than the front teeth. And so we call it the posterior occlusal plane, but we just want to make sure that the back teeth, there's a gentle curvature moving upward as we go back. That, again, follows the curvature of the lip and creates a very beautiful smile. The embrasures, the incisal embrasures, are these small little spaces that we have as the two teeth connect down at the edge of the tooth. And so what we say with these incisal embrasures is that there's a very specific way that these things should be. The depth of the incisal embrasures should be the least deep in the between the two front teeth, and get slightly deeper as we go back between each individual tooth. Now, this is where we can give you a lot of artistic license, because if you want teeth that are square, we can certainly do that, and patients can function with that fine. And if you want teeth that have more curvature to it, we can do that as well. So this is where it helps us if you bring in pictures of smiles that you like, and often the smiles may be determined by both color, but also the shape at the edges of the teeth, where the depth of these incisal embrasures will determine how much curvature there is. Generally speaking, the deeper the incisal embrasure, the more youthful and feminine the smile is. But again, notice when we connect the dots between the embrasures, the smile line, and the papilla, how we have these harmonious curves, which again looks very, very good. The buccal corridor is, we want you to look at the the back teeth in the smile. Look behind the canine teeth in that region and see how much tooth structure is there or not. A lot of patients I find tend to just focus on the 6 teeth, but these teeth are in play, more so on some patients than others. So we take pictures from the front and about 45 degrees to help you to see that, and that gives us a good design. Other thing we want to just look at is just generally how much your lip moves from a full smile or from a rest to a full smile. The more your lip moves, the more we got to make sure the gum line is just right. And so we're going to study this from a couple different views. But if you're one of those people that really have a lot of lip movement, you may have sort of a gummy smile, and there's solutions for that. And we can certainly talk about the different things we can do to get rid of that. The last thing I'm not going to go into too much, but we also will look at the skeletal makeup, the relationship of your upper and lower jaws skeletally. Sometimes we have patients that just have the jaws out of alignment, and we may have to get the help of an orthodontist or even a maxillofacial surgeon to correct those things. But that'll be, again, part of our workup to look at some of these parameters, again, that mean more to dentists than to you, but just understand that we have to consider that. If we do all those things correctly, we can end up with a result like this. They're just very conservative porcelain veneers, bonded to teeth with minimal reduction. And you can see with that, we can get a look that is very, very beautiful and just looks like natural dentition, which is what we want, and hopefully create a very happy patient as we did here. So the process then that we go through is first getting to know you and getting comprehensive data. And again, for those of you that are looking for a dentist maybe in another city or state away from me, please be sure that you get somebody that does a very thorough examination, not only cosmetically, but from a functional standpoint. So general patients that we look at are patients that maybe can come in through hygiene and have a quick exam and some x-rays. But when you start thinking about cosmetic dentistry, this is a patient, you now are a patient that may or may not have problems with your bite or what we call masticatory system. And you need to have a complete evaluation to be sure that you get the result that you want, both aesthetically and functionally. We start our process by taking digital pictures. We have competent dental assistants that can take all these pictures for us, and we take every one of these pictures for a very specific reason. Seems like an awful lot, but they're there to not only help you to see the problem, but for us to make a thorough diagnosis. We're also going to be doing what we call a TMJ Occlusion Examination, which is basically the functional examination to make sure your jaw joints are functioning properly and that your bite is stable. If your bite is not stable, then often while we're doing your cosmetic case, we can do things to your bite to make it more stable. And in fact, what I see a lot in my practice is that there's a lot of patients that have have an unattractive smile because of underlying functional problems. So we're often working out the aesthetics and the occlusion simultaneously together. We'll have our hygienist look at your gums and help us do a biological and structural assessment. We'll of course get a full series of x-rays. We'll take impressions of your mouth, and we'll also mount the models that come from the impression on a device called an articulator so that we can study your bite very, very carefully. So generally in our practice, we gather the data one day, then I'll study it by myself on another day and come up with a plan, and then you'll come back at another appointment and we'll discuss what is going to be best for you. So the treatment planning process then begins after we get that data. And one of the rules that we like to follow is what we call the Whittiam rule. This is Dr. Peter Dawson. He's my mentor and also somebody that I teach with now. And he coined this term, or at least learned it from somewhere. He taught it to me. But the Whittiam rule is, would I do it on me? And we find that the Whittiam rule allows us to do something what I think is very important. And that is when we sit down and look at your case, we're going to think about or figure out the least amount of dentistry that's going to be required to get the result that you would like. And that is going to be something that's very, very important. We're going to take all your data and put it into some software called the Dawson Diagnostic Wizard, named after Peter Dawson. It happens to be something that myself and another dentist named Drew Cobb developed, but it is a treatment planning software that allows us to visualize that. So with that, let's go through a couple cases, and we'll look at Vance's case first. Nice guy who had some dental problems that you'll see in a second, a lot of wear on his teeth and some bonding that has failed, and he is really trying to get a newer smile. And so he had braces as a teenager, had some teeth removed. The teeth are very much angled back, which can still look good, but from a proportion standpoint, they're very short. They don't follow the curvature of the lip, and they're just sort of wearing out. So what we're going to do with Vance is do the process. We'll gather the data, get the photographs, get the models, do our biological and structural assessment. Notice that on the edges of these teeth, those brown areas where this patient has actually worn through the enamel and into the softer dentin. And when you get to that dentin, the wear is faster. So this isn't a bite that's breaking down very rapidly. We'll take the photographs, put them in the wizard. I'm not going to go through all of this, but this is our protocol to determine with the photographs where the teeth should go, both the lower teeth and the upper teeth. And we'll go through and make our determinations very, very specifically what we're going to change at the edge and the gum level and come up with a very basic design two-dimensionally. Once we've done this, we can then transfer that to the models to make sure that it's not only going to work out from an aesthetic standpoint, but that we can also improve his bite. So again, aesthetic design, occlusal or functional design is what we're doing. And so when we finish up with Vance, he's just basically done the uppers at this point in time, but you can start to see that our process of doing it in our mind and doing it in wax and test driving with our temporaries and then going to the final restoration sets up for a very nice look. He was not after a super Hollywood white smile, just wanted to have something that was more natural, and been very happy and very successful with this case. Let's look at another one now of somebody that had some older dentistry, some composite resin put on her teeth, not happy with it. It's been there for a long, long time, over 20 years. It's just sort of wearing out. So in this case, what we're doing is basically just, again, getting some photographs, getting our models, and figuring out how we could change the proportions of the teeth to have them look better. And so notice how she has a very beautiful curve to her lip, but how the edges are flatter. This is where the teeth do not follow that lip line, and that's happened because the older material is composite resin that will wear out. If we transfer this now or do porcelain, porcelain is much more durable and won't imbibe teeth. So notice the difference from before and after and how that better follows the curvature of her lip. We're able to increase the shade, and in this case, again, just doing the upper teeth. The lower teeth were just bleached, and a patient that's pretty, again, happy with the result. So here again, this comes from an understanding of the anatomy of a beautiful smile, first figuring out where the teeth are going to go, and then focus on what is going to be the best material. This is actually an Empress veneer, very thin veneer that is bonded to the tooth structure. Again, when you come in, there are a lot of different types of veneers, different materials, and so be careful if a doctor just sort of does one procedure, that may not be the best thing that can for you. So we want to have a lot of arrows in our quiver when we're thinking about materials. This is another patient who, when you look at her, very beautiful young girl, teeth are small. She has gums that are a little irregular. So this is a patient where we're going to figure out where the teeth go, but also how we're going to change the position of the gum to make this effective. So same exact procedure. We're going to take our photographs. In this procedure, because the gums are puffy, we're going in our pre-op, we're going to also do some treatments of the gum. We're going to do our diagnostic wax up to figure out where the teeth go and the size and shape that we want, so all the proportions that are going to be there. And then when it's all said and done, this is an authentic veneer similar to an Empress material. But here again, going back and doing 8 teeth, doing her first bicuspids as well, we're able to create a full smile. Notice the difference in health in the gum tissue because of the gum work, and notice that the gum has been raised, and that was to create better proportions with the teeth. And a nice look. Sometimes we have scenarios where there's spacing. And one of the things that we notice is if there's a space between the two front teeth, often the lateral incisors, or the teeth second from the front, are small. Those teeth are often pegged or underdeveloped and can throw things off, which create spaces somewhere. So we're going to do the exact same principles. This case was done a long time ago before we had the wizard, but we can still do our measurements and figure out if we were to just close the space on those two front teeth and do nothing to the lateral teeth, she would end up with 2 huge front teeth, which we certainly don't want. If, however, we could basically make the 2 front teeth essentially close the space, but also remove some tooth structure on the outside of the teeth to make room to make the laterals bigger, that would be a great plan, because now we do 4 teeth and we can make them all in proportion to one another. So when you look at her after pictures, this is actually a stacked, what we call contact lens veneer, a different type of porcelain, still bonded to the tooth structure, but allowing us to have the most predictable way to make things really pretty, which is what we certainly want with this case. All right, if you look at it, it almost looks like we moved the 2 front teeth together and made the laterals bigger. That was the illusion we added, and again, with just 4 teeth. Why didn't we do the canines in first buys? Because those teeth were fine. Remember, we're going to do the least amount of dentistry for the maximum result. All right, let's look at the last case, and again, this is a large implant case, but what I want you to see here is that we're still going to be applying the same principles of a good aesthetic design even with full mouth reconstructions on implants like this. This guy has lost all his upper teeth. He only has 6 teeth on the bottom. One of the teeth is broken off at the gum line. He's destroyed his upper denture. We're still going to take impressions and photographs. We're still going to figure out exactly where the teeth need to go. And once we do that, with implant cases, we then take some specific types of x-rays and plan where the implants go. Cone beam is the type of cone beam computerized tomography, which is basically a 3-dimensional x-ray, which allows us to specifically place the implants. But the bottom line is, this is a patient that was put to sleep. Everything was made in advance. He was put to sleep. We put in 5 implants, top and bottom, and then these restorations were actually screwed in place at the time of the surgery. Now imagine that if we didn't have any sort of smile design or any sort of capacity to understand where teeth go, how could that be possible? But yet, even in an extreme case like this, we can get very specific about where we're going to go. And then, of course, this is a long-term temporary that will then be basically turned into a permanent restoration once the implants are ready. So what I've tried to do in this presentation is to give you a glimpse at what's possible. You know, smile design is really an art as much as it is a science. And what I find is that a lot of cosmetic dentistry is done where unfortunately the clinician will just get too into cutting the teeth down. Make sure you find a place where the doctor is going to gather some good data, some photographs, some models, take a good look at your gums and the structure of your teeth, and make a plan that you understand. Make sure you understand the materials that are going in, maybe even research a little bit, ask questions about it. And I think if you follow that process where you then get a temporary that's in your mouth that you can look and check off and make sure you like, that goes a long way to then communicating to the lab in a way that they can give you back something that is going to be dead on. So I appreciate your interest in cosmetic dentistry. Again, I'm John Cranham. I'm at the Chesapeake Center for Complete Dentistry. If we can see you and answer some of your questions, we'd love to do that. So with that, thanks for tuning in, and keep an eye on our website, because we'll be doing patient education type seminars all the time. Until next time, thanks.